I do want to introduce another one of the member of our panelists today who hasn't had the opportunity to introduce himself, Dr. Tony Kuo. Okay, would you mind introducing yourself?
Sure. I'm Tony Kuo. I'm a family medicine, a family physician by training. I wear many hats. One of them is direct chronic disease and injury prevention for the health department. And so bringing a slightly different perspective from the prevention side.
I think Dr. Tony Kuo is very humble. He's published a great deal of work, and he is a population health expert. He works within the LA County Department of Public Health System, as well as faculty over at UCLA. So it's very culture for him to downplay all of his achievements and his record, just like the type of work that he's done within population health. One of the things that I really appreciated about your presentation, Mike, is that he's very specific about the sources of funding, and he didn't sugarcoat what it takes and how much it actually costs to cover and to treat a homeless patient in totality, right? Because it's got to come from somewhere. So I really appreciate you doing that. Shai, here's a question for you. I'm wondering, of all the referrals that you've gotten throughout the LA County systems, and I bet there's many, what percentage of the referrals are you able to take into your services?
So we get referrals from all over the county, and the referrals we get, we're like the highest level of care that is available in the streets because we're so integrated with the court system and the inpatient system. A lot of the referrals, we're one of the premier teams that DMH has, so sometimes referrals come in, but the people are not as acute as they would need to be to access our services. I would say a solid, would you say 60 to 70%, I think we take on. Some of them we have to send back because they're not quite ready for our levels of care, and there's other teams that can actually be more appropriate for the needs of the people that are coming in. But as time goes on, the referring parties start to understand that, okay, the home team takes on the folks that are on the cusp of grave disability, where they are not meaningfully providing for their food, clothing, or shelter because of a mental health condition. So it's the sickest of the sick. So they're not all referrals are that level, but we try, even if it's not our level of care, what we tend to do is respond to the referral, stabilize the individual, get the ball rolling, and then sometimes hand it over to the next team that can take over that level of care because the individual is not that impaired. And we actually have done that with our street medicine partners quite frequently. Get the ball rolling, stabilize someone, and hand it off to the next team rather than just block the referral.
But practice, and how do you train, utilize better the pharmacies in the community, pharmacy technician who could actually even play the community health worker roles, and even more specifically, how do you develop the community CHW workforce so that they could better take advantage? As many of you know, the CalAIM is a wonderful program, but sometimes actually getting the process going is not so easy.
I can comment on, so scaling is something that we are very proud of on the home team, because when we started out in 2019, there was one street psychiatrist and about 60 team members. But under Aubrey's leadership, we have gone to 230 staff members and 17 street psychiatrists. So there's been a dramatic increase. One of the things that we're kind of blessed with is we're coming from the Department of Mental Health. So there are some resources, and the department is committed to expanding our teams. However, what we also did was we integrated the home team with training programs. So different residency programs. So we have different skill sets. We have like nurse practitioner rotations, street psychiatry rotations, nursing students coming in, internship opportunities from different specialties. So we integrated ourselves academically to get actual people interested to come and join the work that we're doing. And we, over the past 5 years, it's this dramatic rise in which the number of more people we're serving has greatly increased. I know you mentioned some numbers, but So if there's 75,000 people experiencing homelessness, about 75% approximately have a mental health condition, and about 25% of that 75% have a severe mental health condition. So home team population is approximately about 10 to 15,000 people that are severely mentally ill and would meet our population, our target population. And if we get about 2,000 new referrals every single year, we're hoping that by about 5 to 7 years, we can really make a huge dent in this super sick population.
Thank you for that. Mike, any comments on your side?
Well, I also second what Chai said. I think our two organizations are examples of groups that have scaled. We went, in under 3 years from a couple people to we have 170 team members and 16 teams. They have 18 teams in a few years as well. Everyone always talks about money. Is there money for this? Is there money for this? The thing that I've been most pleased doing this work is that there is money if you're doing the right thing. There's CalAIM. There's cities and counties that want to fund good work. There's, this year for the first time ever, HRSA, the Health Resource Service Administration, is doing an FQHC street medicine opportunity. The FQHCs get really well reimbursed. So there is a lot of money. I actually think, and this is not just for homeless healthcare, I think one of the biggest crises we have in healthcare right now is a workforce issue, to find good people willing and able to do it. And I think we need to, I think Tony was saying this, think more creatively. We can't hire doctors to chase around, in the streets and do these vans. We don't even have enough. And with an aging population and all that, we need to start thinking about how do we take advantage of nurse practitioners and physician assistants and pharmacists. Community health workers can do tremendous amounts for patients. So I think, and I'm a little bit of a healthy skeptic with artificial intelligence, but I'm also not a Luddite. I think we need to think about how do we take advantage of that to take some of the burden and the workload off us. But I do think for good programs, if you have the right people, there is funding out there to scale it.
That's really reassuring. I wanted to also ask one question before we move on and ask the audience if you have any questions for the panelists. What would you say is the number one challenge? And this is hard because taking care of homeless clients, it's challenging on its own. If you were to name your top challenge working with this population, what would it be? Mike and then Shai.
Good question. What's the hardest challenge? Well, we have two goals: to stabilize the health of the client and then to get them into housing. And it's really hard to line those things up, right? So you do a lot of work, you get them on the right mental health medications, they're open to housing, and then it's not available. And I'll give some props to Mayor Bass. I think, the city of LA has done a good job of buying some motels and creating capacity. That's the positive way of looking at it. My team will say, but there's still not enough. And we still have long waits. And when somebody is ready to make that leap, they've been on the streets and they say, today's the day, I'm going to do it. And you can't say, okay, we can get you in somewhere. It's just such a setback. So we need to have more real-time availability of housing. I wish I had a better answer than that.
Sorry, please. That was it. No. Okay. For me, what I have noticed, the biggest setback or the most challenging thing is that the entire mental health system has not been designed with the needs of people experiencing homelessness in mind, which means that the only way you can do large-scale system navigation is through relationships and not through contracts. Mm-hmm. We've spent the past 5 years building, as I call it, an ecosystem of care because we can actually move people. We built a new system that's built with a new set of rules. And that was the biggest challenge, was getting key players at the table who believed in that mission and were willing to build a new pipeline with you. We spent a long time building those pipelines out, but the problem is sometimes those pipelines get full. Now you have to use, levels of care that are maybe outside of your ecosystem, and you start getting those same breaks coming in. So for us, I think building a system that is actually more equitably available to people experiencing homelessness has been the biggest challenge, but we've been spending the past 5 years to overcome all of that.
100%. I mean, I'm not surprised. I think many of us who have dealt with clients with mental health issues in the past, even if they're not homeless, it's very challenging getting them to the proper care that they need. Tony, I know you had a comment.
Well, I was just going to say that I'm going to kind of out of left field, but I also think public relations, I think, is a big challenge. I think there's, as you see here, there's a lot of great stuff going on, boots on the ground, but in the news, we see all the negative news stories. And I wonder, part of solving the fragmentation, the system fragmentation issue is also understanding how to message to the community.
Tony, I'm just curious, like this is the last question before we go to the audience, but in your work with population health, you've seen it kind of like these different outcome studies and what has worked in terms of scalability in different disease states. Like, are there some that you've seen that are kind of comparable to mental health that would be a good take-home pearl for the street medicine team? I know that's a hard question.
That's a very tough question. I actually look at street medicine and a home team as actually a model, probably potentially for how you actually handle a lot of the other chronic conditions, right? The same challenges they're having, you're seeing it with aging population, you're seeing it with the population with dealing with dementia. It's the same thing. The social network and infrastructure, we're trying to build it, but we're not quite there yet.
Got it.
So before I go to the audience, I actually do have a question for Dr. Kuo. You all probably have heard the recent news that there's a TB outbreak in Long Beach among the homeless population. Dr. Kuo, from a public health perspective, what do you think we need to do? If the number of individuals who are unhoused are increasing, right, and they concentrated in a certain area, what can this two team, one provide primarily physical health services, the other one mental health services, but for the severe mentally ill, what do they need to do from a prevention perspective coming out of COVID?
That's a great question. I think the short answer is I'm not in charge of TB control. So.
But you're from public health.
No, but the long answer is I think, as I mentioned, part of it is we need to do a better job probably building out communication infrastructure so you can actually coordinate complex care. I think that was probably what a number of years ago when the state, before they had CalAIM, they had that whole person care model, or that's what they were trying to do. And I think we're also, from a public health standpoint, we're still trying to learn, even now, post-COVID, because I think COVID actually, pointed to a lot of gaps that I think are not only our healthcare system, but public health system, and probably more importantly, what we found was the social services system probably needs a lot more integration and thoughtful thinking around how to connect the dots.
And I'm sure you all heard about the governor proposed budget for next year that was released last Friday, right? In it, there's a cut, $400 million cut for public health. There's a cut for workforce development. Now, thankfully, or depends on how you feel about Prop 1, at least there's some money there for the behavioral health workforce. So how are we gonna train more people? And let's just not talk about if you start training now, they're not ready to go and do the work 4 or 5 years from now, right? So what innovative solution do you think we should be consider? I think you kind of mentioned about it a bit, Michael, but collectively, how do we do this? How do we bring enough workforce to meet the need? Because, forgive me, you all do wonderful work, but you only serve a sliver of the population, right? And if the number is growing, I'm not sure we're gonna catch up, because you're not talking about just 75,000 people on the street now. We're not able to stop the spigot from spilling the water, right? So are we chasing after something that is bigger than what we could do?
Yes, the problem definitely seems very large and it's getting worse, but the truth is, we need big things, big interventions have small beginnings. And what we have built right now is a way of doing things. This is just the beginning. This is only in the past 5 years. This hasn't even trickled into medical education, into all other parts of education, and it's an elective part of your training. The work that we are doing over here is establishing the foundation that's going to be mandatory training moving forward, so we can take this knowledge and spread it to not just a health force. This is a problem that affects all industries. We all need to understand what the problem is, what the solutions are, engage the community, and it needs to be a mass, nationwide effort from everyone at the table. We've started doing that already by integrating the healthcare training that comes with it, but I think a lot of work needs to be done with our educational institutions to advocate that this training is mandatory.
So you're talking about policy change now, aren't you?
I think ultimately, there needs to be momentum to kind of enforce policy change, and I think we're building that momentum right now. So I am actually very hopeful about which direction this is going in, because we do have a lot of that energy behind us. We'll just need more of it to snowball into in the right direction.
Question from the audience, please. I'm coming. Please state your name and who you're with.
Hi everybody, I'm Nadia. Yes, I have an Australian accent. I'm being sponsored by the company called Share. We do collaborative housing. We have a booth over there, have a table over there. Come and find out about it. So I just have a question as an individual. I live in Hollywood and I'm passing homeless people all of the time. I know that they move around. They're not going to be ready for the collaborative housing program. So how would I refer them to you? Do I refer them to you? Do I call you? Do I tell them about you? This is for you, Shayan. Thank you.
Thank you for that question. I think the most important, how do you get people connected? And there are so many resources. I mean, I'm kind of embarrassed to say this, but as I was training to become a physician, no one even told me about outreach, and I was never really exposed to it. There is an entire platoon of outreach workers who are trying to connect with folks, but they need the community to make them aware of where individuals are and where they're kind of located so they can meet them. There is something, the LASA, which does a lot of the general outreach, has an outreach portal. It's called LA HOP, LA Homeless Outreach Portal, where you can go and any citizen can complete a referral, and within 24 to 72 hours, an outreach team will go connect with that individual into that general outreach network, and referrals will come to us, and that will directly link you, the individual, with the teams that are doing this work all the time. LA HOP, LA-HOP, and I can come show you the link in a little bit, but you can look it up on your phone. You can make referrals from your phone. It's pretty easy to find.
And I know you said you're in Hollywood, but I want to give a shout out to your neighbor, West Hollywood, the city of West Hollywood. They have set up a phone line that their community members can call when there's someone who's unhoused and in need of help. And then we're call A for medical approach. And then the police are option B if it's a safety, public health situation. I'd love to see other cities and municipalities do something like that.
And also the Department of Mental Health has a beautiful new program called Hollywood 2.0, which is kind of redefining the way mental health services are delivered in that area. It's a huge initiative with a lot of funding behind it. We can also offer you more information about that new ecosystem that's developing over there and how to make referrals.
So I know we started this 30-minute late, so we're going to push the time a little bit for 30 minutes, so we're supposed to end by 10:25. So I'm going to ask you, if you need to go to the restroom or take a break, just get up and go, because we're going to keep going. And then all of you probably used to eating lunch about 10 minutes, right? So we're going to take 30 minutes from your lunch so that we can catch up, right? Because this is so important. I don't want to cut this conversation now, okay? So here's the question.
Hello, my name is Sylvia. I work for SUDIS. We're a Safe Syringe program. I'm a program coordinator. I had a question. Have you guys seen any tranq cases, xylazine?
I have actually seen one, the street, I work with USC Street Medicine, and one of one of the patients that was referred to me, it was, had a pretty serious wound that they believe was from tranq. By the time I got in, the wound was already healing, but I personally have not, but I believe the reports that I got that this individual was using tranq.
Yeah, we've seen a handful of them. For those of you not familiar, it's a street drug, and when it's injected for whatever reason, it causes these terrible wounds. It requires a lot of wound care. We've seen a couple of them, so it's definitely not pleasant when someone has one.
Yes, hi. My name is Huda Kare Detlefs. I'm a Pharm.D and Plus, and I own a consulting company for long-term care. So I consult for nursing homes, a lot of psychiatric facilities, and homeless residents, they constitute a very substantial number of our residents. My question is, this is unbelievably incredible. What I just heard, it's amazing, so I congratulate you. But I watched many documentaries on television. I talk to people, and the big question is the sustainability of this program. It is really impressive to get these people to actually go and get seen and to be housed. But what kind of coordination and what other agencies you are working with to make sure that there is sustainability? Long-acting antipsychotics, etc., is, of course, this is a tremendous way to go. But how do you ensure that? How do you ensure these people are gonna stay housed? Because from what I understand, that there is always a tendency to go back to the streets, and there's always a tendency to use again, and we keep seeing them being recycled in the system. I work in Orange County, I see them in San Diego, they get recycled to LA, etc., etc. So I'm just very interested and very curious as to what these plans are.
I can tell you how we do it. What I have noticed is a lot of the times when you house people without support structures in place, that housing will not last. If you notice in our model, it takes about 3 to 5 months. And during that time, what's happening is that individual who has been disconnected from community doesn't have the support of maybe a family or friends who can motivate that individual. We are building that bond. And we stay connected with that individual once they get housed. We only house people in facilities where we know everybody. We know that staff will work extra hard to keep that individual housed. We have different programs to help provide skills to keep them anchored in that housing. And if substance use does take place, the facility just doesn't kick them out. It works with them to manage the substance use. So we actually have an entire recovery plan built after housing. And I feel very fortunate with my team that we have gotten to the point where we are thinking beyond housing. It's almost easy now to get someone indoors, but keeping them there is what, you're absolutely right, how do you sustain that? And we have done it by actually creating an entire aftercare plan once people get housed, with the option to refer back to our team if they slide back, that we will step back in and then make sure they're housed again. And if that cycle continues and continues and continues, in the rare situations, we will use the court system and try and conserve someone to at least help facilitate their recovery if they're making bad decisions driven by their mental illness.
Yeah, and I would say my expertise is on the healthcare side, so I'm a little bit speaking anecdotally outside of my area of expertise, but it's just such an important problem what you highlighted. So the problem is there's both not enough places for folks to go and not enough good places to go. So I'm thinking of somebody I saw this week, and he finally got placed in housing out in Lancaster. And he had this great community he was living with in this encampment, and it's not the community I would want or you would want, and it wasn't the healthiest community, but it was a community. And he had a quality of life there, and then he got sent to Lancaster, and he's doesn't know anybody. It's a very sterile building, from what I understand, and he's been having a really hard time, and I think there's a very good chance he's going to end up back on the streets. There's also supportive housing, which is an incredible shortage. So there's folks who, especially with severe mental illness or other disabilities, they could get housed, but they need to be somewhere where there's a case manager or somebody to look over them. And there's just not enough about that. This is me sort of going a little bit outside of my expertise. I mean, I think we have to start getting more creative with other options. I see all these big businesses, corporate headquarters downtown that are unused, and that could be a space. And I know there's zoning rules and things like that. Culver City in San Diego have experimented with safe sleeping sites. They're camping sites. It's not perfect. It's not ideal, but we've seen some people do really well with those types of setups.
I've also kind of noticed that, from the people that I work with, a lot of people want housing. They want to do better, and sometimes their resources aren't really there. But it's in its essence, a team needs to build a human connection with an individual, and that human connection is what keeps people kind of going, keeps them away from drugs, and motivates them to want better for themselves. And if that isn't present, then all sort of housing and all treatment plans will kind of fall apart.